So let's start talking about women. I'm very impressed, my gentleman, for joining. Okay, the man at the front is already wondering whether he can actually whiz out. The doors have been locked. So my name's Dawn Adamson. I'm a slightly weird cardiologist in the fact that I'm an interventional cardiologist. It is quite hard to say. My mum still calls me an interfering cardiologist. I have to point out that's not quite correct. I also do adult congenital heart disease and I do obstetric cardiology. So just because I'm so old that I was trained at a time when things were slightly more flexible, plus I'm quite bullshit. So I decided that doing one thing was not what I wanted to do. So I insisted that they let me do more than one. As such, I tend to be involved in patients with cardiomyopathy from virtually every etiology you can think about. So it is something that I think is really important, and thank you for giving us the chance to talk about this. So I was asked if I'd just add on a slide to my pregnancy talk, and then it became an hour talk. So I apologise if there's areas that I haven't thought about discussing, but that's hopefully where we can all be part of the discussion later. So why is women's health and heart disease important? Well, quite basically, we know that heart disease is the major cause of death in the UK, and we all get very upset and very concerned when we talk about cancer. Don't worry, we started early, so you're not late. It's just we've been bad. That's what we're going to do. Women are bad. So basically, coronary heart disease, far much greater risk of problems than cancer, stroke, and then cardiovascular disease altogether is definitely a thing. And obviously, whenever we talk about mortality, that's just the tip of the iceberg. There are many, many people who have these conditions that survive with it and live with it and have all the problems with it. However, coronary heart disease is the leading cause of death in women. It affects 8% of all female, it's 8% of all female deaths. The good news is it rarely causes death before the sixth decade because of the fact that we think the oestrogen is protective, but it is the commonest cause of death over the age of 60. And I think we just don't really think about this. And, it hit Time magazine, which the fact that women's health actually hit the front pages is such an important publication. And that is because worldwide, 8.6 million women are dying from heart disease each year. And that's accounting to a third of all the deaths of women, okay? And so it was, raised at really a time to sort of think about it. And the thing is these are quite shocking statistics that we don't necessarily think about. However, what is very shocking, and this data is always a little bit delayed because there's always processing, unfortunately. But when you look at the outcome, and the data comes from America, as you know, America are full of data because it's data that drives the funding. They don't get paid if they don't put the data in. So the minute money's involved, there's lots of data. And you'll see that back in the 1980s, if this was the mortality for men and women, okay, and as the mortality is improved in men, it hasn't really done an awful lot in women. Thus meaning the gender gap now is absolutely huge. And so we've got to think about why. So all people always ask the question, are women different from men? I apologise. You can leave if you want to. Okay, the answer is clearly. So why? So we know that under the age of 50, if you have a heart attack as a woman, you're twice as likely to die from it than if you're a man. Exactly the same condition, twice as likely to die from it. In the US, because obviously they've got the data, deaths from MI kill 6 times as many women as breast cancer. Now, when you think about the amount of education, literature, publications about teaching women about breast health, to look for lumps, what to do, how many people have worn pink, have gone for a run, walk, shuffle, for breast cancer charity, the amount of work that has been done for breast cancer, raising awareness, is absolutely huge, and credit to the charities and the foundations that are doing that work. but actually it's MIs that is killing women. And so I think we've all got a job to start really raising awareness and trying to, do something about it. Since 1984, more women than men have actually died each year from heart disease. And as I was just showing you, this gap between survival continues to increase. So why is it some of it? Well, the first thing is, and I can say this as a woman, is we're not the easiest people to read. You can nod now, you can go. And the problem is, the adverts, you've all seen the adverts of the man with the belt around his chest. And recently I was part of the team that filmed the advert. I don't know if you saw the man on the side of the dual carriageway that had a heart attack. That went out as a media campaign. And so this sort of central crushing chest pain, which goes up to your neck and down, and down your arm, which commonly occurs in men, tends not to occur in women. The majority of women have very atypical, non-specific symptoms at the beginning, okay? So, we are different, we present different, we haven't got the classical risk factors, the classical presentations. And therefore, if you pitch up with this kind of slightly non-specific, wishy-washy type of pain, the medical professionals don't suddenly think, oh, this could be a heart attack. So often it's by the time that you're really starting to become unwell, do people start to think about putting an ECG on you, and it's only then do people start to, diagnose it. By which time, because the thing with heart attacks is every minute that goes by, basically minutes equals muscle. So the more the artery is occluded, the more the lack of the blood supply to the muscle, the more muscle dies, and therefore, the bigger the heart attack and the more complications and the higher the risk. So time is critical. Heart attacks are time critical like strokes are. But if we're not going to really present with clinical symptoms, most women will sit at home and just ignore it, carry on, but think it's a bit of indigestion, and then by the time they pitch up with quite wishy-washy symptoms, then they're not picked up, and you can see how it all continues. The other thing is we always assume that heart attacks occur in men because women have got estrogen and that's protective. But we now know that the biggest smokers in the UK are actually young women. Okay, so smoking, diabetes, increased BMI and abnormal lipids are erasing the cardioprotection of women. Okay, and so all of this is starting to take away the protection we had. And then somebody did this study, and I do apologise, but it still makes me slightly giggle. It's all down to, it's all down to men, okay? So basically, it's not our fault, it's the men's fault. Okay. So as we were saying, the other thing as well is women are much more likely to present with something called menoca. So what menoca is basically MI, myocardial infarction or heart attack, with non-obstructive coronary arteries. In other words, we take an angiogram and your arteries are all normal. Now, I know that in 20 years ago, if you had a heart attack, all the symptoms of a heart attack, and then we did a coronary angiogram and it was all normal, they'd just kind of, the men, because all the interventional cardiologists, men would just raise their eyes and just go hormonal, mad, both. Okay, but now we realise that menoca is a situation, and actually that women are much more likely to have what was syndrome X, which is now rebadged as menoca, which is where actually our arteries go into spasm. So they shut right down, but actually they open back up again. So the good news is it's not prognostic. It's not associated with the increased mortality like a standard heart attack is, but we present with where even when we do a coronary angiogram, our arteries don't look the same, okay? The other thing is something called coronary artery dissection, or SCAD, spontaneous coronary artery dissection. So instead of having a third artery, which then breaks open and all the sort of clot and the cholesterol coming out, actually the artery tears. And it's because of like a massive stress response. And so, again, that's very common, far more common in women, and particularly around the pregnancy or postpartum time. And then finally, there's a condition called Takotsubo cardiomyopathy. Now, Takotsubo stands for octopus part. So you see, you didn't know that I was fluent in Japanese. It's the only Japanese I know, so it'd be great when I go to Japan, particularly as I don't eat seafood. But the reason why that is the bottom part of your heart balloons and the top part squeezes down, so the shape looks like an octopus pod. Should you ever want to go catching octopi, is it octopi? Multiple octopuses, who knows? Whatever you want to do, that's what you need, the shape of a pot, because they kind of get in and can't get out. And we now know that this is we call it broken heart syndrome or stress cardiomyopathy, and it's a situation where your heart basically goes into this massive stress response and sort of behaves quite abnormally. And again, majority of people recover from it. It does occur more in women, and but we have seen people not survive it. So I think again it was a kind of women getting stressed, coming in, and then all getting better and going out again, and people not really understanding that there is difference in physiology. This isn't just all about women getting stressed, because a lot of women actually cope. Actually, if you look at life when they do the research, is our levels of coping are often quite higher than men's. So it's, I'm not anti-men at all. I'm just telling you what facts are. I'm joking. So for all these very atypical symptoms that don't quite fit with standard science, and which have hormonal and stress responses associated with them, you can see how, as well as not presenting in a classical way, that by having all these sort of more complex issues surrounding presentations, that we therefore don't get necessarily picked up, understood and managed in the same way. So what can we do to improve women's health? So we all know the standard things that we should be doing: smoking cessation, increasing physical activity, lovely heart healthy diet, weight reduction and maintenance, attending cardiac rehabilitation, and we can talk a little bit about things like omega-3s. And also, there's a lot of data to show that mood has a big effect on your recovery as well. So if we start looking at those in a little bit more detail, so this is some work. I still keep this slide because they've actually updated it now, because obviously we've lost Victoria Wood, but we all love Victoria Wood, so I do like to keep it on there to remind me of just how amazing she was. So I think the first thing we need to be doing is thinking about education. So educating women about heart health and how to stay healthy, and how to be aware that you're not going to have the central crushing chest pain. So if you don't feel right, and when you don't feel right, that we give you that empowerment, that voice to come forward and say, do you know what, I'm not right and I do need to go and see someone. If anything, that's so important now, because we've all seen that there aren't any ambulances, and we've all seen the state of the NHS. So how many people are going to say, I don't feel quite right, but I don't want to bother anybody? Okay, we're all nodding. We've all been there. I was pregnant with severe abdo pain, and I stayed at home, and it's only when my baby was delivered a little bit early for a number of reasons. There was a massive placental abruption. I nearly lost my baby for being too tough. And I don't know what made me do it, because I'm sensible with patients, and I tell patients off if they did things like that. But there's something in us that is a coping mechanism, that we cope and don't bother other people. It's what's intrinsic to our chromosomes, I think, in the majority of times. So actually it's about saying to women, do you know what? You might need to just be thinking, if things aren't right, just pushing yourself a little bit more to the forward, to make sure you present. We know that smoking is bad in everybody, and certainly we know that the more you smoke, the risk goes up. But again, increasingly the fact that that younger people are starting to be the ones that were taking up smoking. I think there is a bit of a change with vaping, but again, that's almost been taken as okay and normal. And so actually it's about really trying to make sure that we put that education, back into schools on the importance of health from an early, because I think we talk about prevention, but actually we never really talk about healthy heart education. So we often sort of talk about how to give up things in later life to prevent the final events. But actually, what about taking kids in school and teaching them from an early age about how to be healthy, not just for physical, but for mental health and lots of other things. I think, it's all great to learn about geometry and algebra and the history of 1066, but nobody actually teaches kids about mental and physical health. And yet it's the thing that's going to affect you throughout your life. But again, this is about sea change, about how we make differences in a lot of the things that we do. We all know that we should be doing some exercise. Obviously, that was me a few years ago. This is me now. You know what I mean? And again, we've actually made a change. So at one point, we were trying to encourage women to go into the gym, which is absolutely fantastic if you look like that. But some of you do, most of us don't. And so the question is what were we doing? So I think increasingly we have now set up cardiac rehab and gyms for sort of women-only sessions. And I think, where women can actually feel more comfortable and empowered. And that is even more important in areas where for different people with sort of black and ethnic minorities, particularly Asian women, were not feeling comfortable going into a gym with men, or particularly if they were having to try and exercise fully dressed. So it's about trying to understand how we support women of all ages, shapes, sizes, and ethnic genders to actually be comfortable in going to take up exercise. And actually, this sort of exercise isn't great for everybody. If you can run, fantastic, but some people don't enjoy the gym. So it's about thinking about different exercises that are good for different people. And I think that's starting to be built into a lot of places, but again, to really quite encourage that. And then we've got the dreaded menopause. Now, it wasn't that long ago that one just didn't talk about the menopause. Now, suddenly it seems to be the thing that everybody's talking about, isn't it? It's on the front of everybody's minds. So I think it would not be appropriate to be talking about women's and health and heart health without discussing it. So I'm going to start by putting up a government health warning, okay? And the fact is, I'm a cardiologist. I am not a gynecologist. So I am going to tell you my thoughts about hormones, hormone replacement therapy in the heart, but please do not go to the world and say, this is what Dawn says, because I am not an expert. I am giving you a sort of physician's approach to it. Okay, so it is important that people take this, not necessarily with a pinch of salt, because I do obstetric cardiology, I therefore do contraception, I do work with my gynecology colleagues, but I am definitely not a world expert on the menopause. So we all know what it is. It's a stage in everyone's life where the ovaries start making eggs, and so you produce less hormones. The average age is about 51. Some people are later and some people are early. And it tends to be gradual unless you've had your ovaries removed for, they've had to be taken out for some medical reason. And so the time that as you lead up to it, we call them perimenopause. And some people notice it because that's when your periods might be becoming a bit more heavier and irregular. And this often starts around 45, but again, increasingly a number of women are using things like the Mirena, fantastic coil, and therefore you may not notice you're going through it because actually you're not having periods. So if you're not, then people don't necessarily, realise it. And I think in the past it was hot flushes. The menopause was hot flushes, full stop. And the thing is yes, you can get hot flushes. Okay, but it actually can include an awful lot more. So it can make you very tired and fatigued. It can give you palpitations. So if you're suddenly in your 50s and getting palpitations, you're going to be worried you might have a heart condition. You can get a lot of muscle pain, joint aches, fatigue, poor concentration. That's the thing that a lot of women, that complain of. And particularly for women in their 50s, it may be that they've, put their career on hold or slowed it down while they have children. And they're now really ramping up at a time in their life. And then suddenly everything becomes a bit of a brain fog. You can get quite low mood, anxious, your libido, may just be out of the window. And, occasionally you can get urinary incontinence. So, it's all good, isn't it? It really varies. It varies how much it affects you. For some women, it lasts about 3 months. For those of you who are really lucky, it can last up to 10 years. Okay, and there's no way of looking at any individual to know how long it will predict. So, and I think the problem is there are some people who are experts in the menopause and the best way to treat it, but it's been left predominantly with the GPs. And most GPs have been given quite a standard, here's your 1 or 2 tablets. If it doesn't work, double it. And if it doesn't work, add that, and that's it, sort of thing. But actually, some different women need different sort of regimes, really dependent upon the symptoms and things like that. So I think what was treated as the menopause and there's one, tablet A or tablet B, I think we're realising is a lot more complex. And we've probably got a lot more research to do in this area to try and make sure that we're supporting what is a normal physiological phenomenon, but sort of getting through, women through it easily. So up until the end of the 20th century, we all thought estrogen was protective. So we thought that, you men had your heart attacks, but we had our estrogen. And we had to have something. If we had to go through all of this, pregnancy, childbirth, menopause, we might as well have had something good out of it. And that good was your cardio protection. And, many cohort studies which looked at HRT, hormone replacement therapy, seemed to suggest about a 40 to 50% reduction in the, in coronary heart disease. So then they sensibly took something called the Women's Health Initiative, and they randomized women to say, right, you're just not, you're going to go standard, not have any HRT, and we're going to give you HRT, and we're going to prove, because the problem with cohort studies is you might find that only those with really bad symptoms went on to HRT, or only people who, there was a particular HRT expert in the area went on to it. So they're always prone to bias. So the only way to test whether something really is accurate is to randomize people, where the patients don't know, the physicians don't know, to either placebo, stick on plaster from superdrug HRT, okay? And they were hoping that this would show that it was really beneficial in women, and that way all women would get HRT, so we wouldn't have any symptoms and we wouldn't die of heart disease. Happy days, holy grail. But what it actually found is an early, albeit transient, increased risk in coronary heart disease in those patients that were having the combined, so the estrogen progesterone. So just to let you know that HRT comes in 2 forms. Everybody has estrogen, which is the thing that we're trying to replace. But the problem with just having what we call unopposed estrogen, so naturally, I'm not going to give you a whole, you'd be glad to know, a whole lecture on the normal cycle, is that the estrogen obviously builds up the lining of the womb, and then the progesterone gets rid of it. So you can give estrogen to patients who've had a hysterectomy because they can't build up a womb lining. And the problem is, if we then didn't give you progesterone and then get rid of that womb lining, then that's what can sit there and become cancerous. So you could only have pure estrogen if you'd had a hysterectomy. And hysterectomies are fairly major surgery. And we now only do them really for quite, a small group of patients. At one point, they were whipping them out, in a hope that to make life easy for lots of women, particularly if you're regular bleeding. But now that we've got Marinas and all these different treatments, hysterectomy is really just left for people who've either got cancer or, sort of bleeding that's resistant to all the other treatments, because it is a major surgery and people really do struggle with it, getting over it afterwards. So suddenly this holy grail of this is going to actually make us live forever and make us feel better, suddenly the headlines became hormone replacement kills women. And all women were suddenly being taken off their HRT if they had any risk factors or they had any history of coronary artery disease. We were constantly being faced with, and as the only female cardiologist in the department, just because I was female meant that of course I knew all about it. But I had to go and soon find out all about it, what we were going to do. And then they looked into it a little bit more, and they realised that actually the reduced risk was still there in women between age 50 and 69. And actually the increased risk was more in the older women. And then they realised that actually for older women, as you get older, your estrogens naturally drop anyway. So actually the dose that they were giving was probably too high for the older women. And therefore, estrogen, if you give it in too high a dose,
can become pro-thrombotic, can make your blood stick and make you more prone. So I think they realised that by giving everybody the same dose, we were probably treating the younger patients who were going through the menopause and needed higher doses right, but the older women wrong. And then that skewed the whole study. Okay, so but I'm sure if I should have asked actually how many of you think HRT is good and HRT is bad. GPs, a lot of the general public still have got this thing in their head that HRT is bad and dangerous, and especially for people with heart disease and causes heart disease. But actually, it may not be. And so what they found is women in this trial who'd started their HRT within 10 years of the menopause had actually a far lower risk of any problems than for women who'd started it later. And then they've done subsequent review of all the meta-analyses, and they found that as long as you take it below the age of 60 or within 10 years of your menopause starting, then that protection still seems to be there. But again, I don't think these messages are getting out clearly. And even now, the gynecologists are still having slight debates, because if you think that coronary artery disease is Britain's biggest killer, if you think that there's 6 times increasing heart attacks than breast cancer, if you think that every woman is having the menopause, you are going to have someone on HRT having a heart attack because it's just too frequent. And then that puts it back in, I knew I shouldn't have done that. Well, no, it's just that it's going to happen. You know, somebody's going to get in a car and have a road traffic accident because there is a frequency that you can't take away. That doesn't mean to say all cars are dangerous, but it's about how we deal with these statistics, all right? So there is still a little bit of controversy over there, but this is all the consensus from the British Menopause Society. You know what I mean? So what I'm trying to tell you is, in effect, where we think we are now, which is a little bit more balanced. What else can we do to try and improve women's health? Well, there's certain things. So we know that women are underrepresented in clinical trials. And so actually it's only by being part of these trials that we know the effect of all these different treatments in women. That's partly because medico-legally, the drug pharmaceutical companies have to have a caveat that says you cannot become pregnant. And that doesn't include taking the contraception, because any woman might forget to take the contraception, or the contraception may fail. So any women that can often go into pharmaceutical trials are women that have either been sterilised or had a hysterectomy. So that really cuts out the majority of women. So it means that all the trials, we're trialling new therapies predominantly in men and assuming that it'll just work in women. So we're really trying to look to try and increase the inclusion of women in clinical trials, if obviously if they want to be. As we talked about, I think there's insufficient awareness both amongst women ourselves, but also physicians of sort of, the differences between the sex, so sex-specific symptoms in things like the presentation of cardiovascular disease. There is still a disproportionate number of women in medicine and in cardiology. So now if you look at medical school, compared to when I went to medical school, there is about, I think it's 54% of medical students are now women. However, if you look at cardiology and ask how many consultant cardiologists are women, any idea? So it's about 10 to 12. And intervention, which is what I do, which is where I put stents in and treat people with coronary artery disease, it's 6%. Okay, so I've got 14 consultants. They're all men. Okay, and that's not necessarily a bad thing. I'm not saying male physicians and male cardiologists are not good, but the fact is that increasingly, if we're going to, be able to have an understanding, it can't just be one person trying to have a little lone voice. So the good thing is that British Cardiac Society now and the European Society of Cardiology, both the major societies of cardiology, including the Americans, are trying to, we've got now women in cardiology groups. We're trying to look at why women go into, these specialties. It is still seen as a male-dominated. It's seen as you can't do it with kids. I've got 2 boys. still alive just. Can't say it's been easy, but I am now a whiz kid with sticky notes, and my fridge does not look clean. It's got more, it looks like a battlefield. You know what I mean? There's plans of anything. I call it Operation Saturday. Get child up at 6, get him to Operation Chameleon, get on train, come here. I've got to get back to pick him up at 7, and I've got to get ready because it's rugby tomorrow, and the other one's playing rugby tonight, so I've got to put it in the washing machine, and I've got it all down in little dots. So you can do it, but you've got to be super organised and possibly have supportive people around you. You know what I mean? But it can all be done. So we're trying to educate women to say, do you know what? Yeah, maybe as a more surgical specialty and a more interventional and a more 24-hour emergency specialty, it takes a little bit more planning. But if you want to do it, it still can be done. There's a lot of bullying that's been unfortunately shown in all of the surgical specialties. And so again, we're trying to address all of that. So hopefully there'll be lots more women in cardiology. There's a huge disparity in the outcomes of morbidity and mortality across Europe. So if you have a heart attack, you're 13 times more likely to die from it in Lithuania than you are in France if you're a woman, but only 8 times if you're a man. You know, so it's not just in the UK, it is a worldwide problem. What's interesting is we're trying to do this gender balance of the team. And again, if you are a female patient looked after a female physician, you're 2 to 3 times more likely to survive than if you were looked after by a male physician. Now, this does not mean male cardiologists, male physicians are bad, because they're not. Some of them have trained me, and I have the utmost respect, and they're up there on a pedestal. You know, I wanted to be them, I'm trying to be them. So I think there are many, many women and, you know, that have been trained and respect their sort of male mentors hugely. But I think it is that just they, you know, unless they've been educated, and maybe by us just being more involved with it, because we've gone through it and experienced it, we're much more likely to be able to pick up. And certainly I know that when I see women who are a little bit, it's not quite fitting, I will investigate them. Whereas if it was a man, I might not have done, because actually I know that my threshold of niggle needs to be reduced in women. Okay, and that was, you know, data on 1.3 million people from Florida. So we know it's there. So another reason why it is important that we tend to try and gender balance the team. So we've got a lot of joined up thinking to do, a lot of planning between both all the healthcare professionals and everybody that's involved in women's health. And I think at that point I will leave it there and open up for questions. Do you want a roving mic?
I was just going to say thank you very much. We've actually got longer for questions because this session goes on till 3:30. So because Dawn's finished early, so please just remember that this is being recorded. So try to ensure to keep sort of personal condition treatment stuff out of it. And yeah, I'll be handing the mic. So if you want to ask a question, just stick your hand up, please, and I'll bring it to you.
Thank you. It's a fantastic talk. Thank you so much. It was brilliant. Do you know, sort of going sort of into the medical schools, the universities, is women's heart health on the curriculum?
I don't think it is, because I don't think it's even on the curriculum for cardiology registrars. So once you've qualified, you do a little bit of medicine, a little bit of surgery, and then you start to specialise into, you know, medical as an SHO, and then you choose to do cardiology. We haven't necessarily got women's, you know, health within even our specialist cardiology curriculum. We're starting to build it in. We're starting to do women in cardiology groups, but that's probably more aimed at trying to encourage women to get into the specialty and not be frightened of it. But I think it's being looked at, but it's definitely not there yet.
Okay, so you know, as women, we could start to lobby that it's necessary part of the curriculum for trainee doctors. Or
no, absolutely. Yes. I mean, I think the first tipping point was the realisation and understanding that there is a difference, and that difference wasn't all just, you know, hormones and emotion. Do you know what I mean? There is a lot of physical changes that make it different. And so you know, go back 10, 20 years ago, these sort of conversations were never discussed. And if there was a talk on women and heart disease, no one would attend, and it would be a bit like, move on. Now, in virtually every conference, it is discussed. There are now whole conferences about it. There are people that are starting to specialise in it. You know, go back 5 years ago, I don't think anyone was talking about the menopause, whereas now it's hitting the headlines. So I think that the tipping point, we're starting to talk about it. And once people start to talk about it, then becomes the awareness. And then that combination is what hopefully will start to drive. But yes, we as a group within all the different societies are starting to push for it all.
Great, thank you.
It was an excellent talk. I'm a retired flying doctor from Australia. I always wondered, I know your talk gave a good insight about the incidence of increased morbidity and mortality in females. And I just want to ask you, is there any study showing the relationship between the women's stress, multitasking, related to increased morbidity in cardiac diseases? Is there any study in the literature? Not
that I'm aware of.
Because
I mean, I'm not the world's expert of heart disease in women. It's just, you know, being a woman and involved in lots of areas that involve women, it's something that I've taken a personal interest in. I don't think there is, and I think possibly because it's quite hard to quantify. Because I think, again, we're only starting to realise that just simple things like going to work while still running the home, that's an awful lot of work that is never naturally seen as work. So you've got a job and what you do and everything at home is just, do you know what I mean? And, you know, I see it more and more in doing the pregnancy clinic, and I just say, look, you need to rest. You need to get your husband. And they say, well, I've got kids. And I say, well, they're still capable. If you can, you know, put on the rugby kit and get it washed and get them to school and pack their lunches and put the Tesco order in, whatever, they're still capable of doing it. But we have still, as a society, got a little bit of that male and female role, and certain cultures have got it even greater. So I really just don't think we've got an understanding, the perception of the volume of work and stress that's involved in just day-to-day running of life, and how that then impacts. So I'm not aware of it, and I'm not so sure how you'd quantify it, but I think it would be interesting if you could.
Yeah, because nowadays there are a lot of tools for assessing the, the stress and things. A lot of tools available, so that's why I asked you.
It would be really interesting. I guess the problem as well with it, assessing something like that, is what would you do with it if you found out that actually they were at higher levels of stress? Does that mean that we would have stress removed from us?
Because we used to transfer a lot of people from remote areas. You know, Australia is a big place.
Yeah.
From the mining area, people who are really stressed, living single, away from the family, and stressed. I used to ask them, you know, when we are transferring the patient, it's a long flight, 2-3 hours, we transfer the patient. So I used to ask them, are you stressed? They said, yes. So young people, I used to transfer with the myocardial infarction. We thrombolize them and take them to the either hospitals. So stress, because I have not seen any study done regarding this stress and the number of cardiac morbidities.
Yeah, I'm sure it's there, because things like Takotsubo, which is related to stress, we just see far more predominantly in women. So I think women probably do run a higher level of sort of stress hormones, but it's probably assumed rather than actually measured. But I've not seen the research. But I think that'd be really important. And I think it's going to be more important, because we at the moment are seeing in the hospital I'm working at, I was talking to a gentleman who's involved in some mental health work. We are seeing kids coming in what we call crisis. So kids in crisis is where they're having suicidal thoughts and need to be 24-hour clock watched. You know, and we used to sort of very occasionally have one in our hospital. We had 22 last week. and why? What is happening? And I think there is huge amounts of mental health amongst teenagers and people in their 20s and 30s. I think there's probably a huge amount of anxiety and stress amongst the whole population. And I'm starting to see increasingly patients who have been massively copic and then not, and then going, what is wrong with me? And trying to find a physical reason. And, you know, you talk about stress, and one of those things, I'm always careful not to put everything down to stress, but I think we can't underestimate the impact of stress on physical health. And, you know, let's face it, you open up the papers and every day is just misery. So I think COVID certainly didn't help, but, you know, even though we're out of it, kind of, I think there's still so much levels of heightened anxiety and stress anyway. So whether that's going to have, you know, whether we're going to start seeing more and more will be, only time will tell. I think it's a really important point. Thank you, and thank you for being, you know, a male and listening and being interested, because it's, you know, it is really important. So thank you.
Sorry, I wanted to ask a question, specifically around women, are, I suppose, the age of 45 onwards, who are in that menopausal state, have been diagnosed with a heart condition and the importance of oestrogen. How do we educate the male cardiologists that this is an important aspect of their testing, as well as iron levels and vitamin D levels, especially given the fatigue phenomena that a lot of women suffer, and fatigue being a symptom that a lot of people with heart conditions have. Yeah. Because it's been my experience, unfortunately, that that's been completely discounted as looked at all. And I was very surprised to experience that, but I was also surprised when I saw your proof of the importance of estrogen and how many ladies of a certain age get missed with heart conditions, and the importance to maintain our heart health as long as possible.
It's a good question. I don't know that I've got the answers how we do it. I think the WHI trial really upset people, because it took a concept of thinking it was protective and then finding the opposite, and for some women it was wrong. And so when if you give something and you get it wrong, that's harm. I think what we don't necessarily equally say, that if you don't give something, that might equally be harmful to that individual. But no one can almost, you know what I mean, sort of, people have become very medico-legal and very concerned. And I think the problem with cardiovascular disease is we run by trials, big trials, tens of thousands of patients. And that's where all the, you know, treatments for cardiomyopathy have been shown in very robust, fantastic clinical trials. And so I think the problem is when there's things that aren't in clinical trials, people aren't keen to consider it, or and that's where it's difficult, because this work was done in a, you know, particular subsection of cardiovascular disease. And I think what the British Menopause Society is saying is don't discount the protective benefits, because actually when you look at all the trials put together, that benefit that we thought was there, we are still seeing. But until we start doing some randomized trials in all these different cardiovascular groups of hormone replacement therapy, I think it's going to be really difficult. Now, the other thing that added to it is, as I'm sure you all know, we ran out of hormone replacement therapy quite recently. And so no one, you know, at the moment, the pharmaceutical companies don't really wanting to be investing in, you know, giving more of it, because they haven't actually got enough to make at the moment. So I suspect, roll ahead 20 years, we will have some of this data, because it, you know, because of the fact we're talking about menopause all the time, and because people are asking about it all the time, we're gonna, and even if we don't have the randomized trials, more and more women are being put on HRT that in the past you just literally had to crawl into your GP surgery, you know, drenched in sweat before they'd even consider giving it you. Now it is being offered out much more frequently. So whether or not we'll be able to look at cohort studies back But I think it's going to be a case of keep talking about it and keep pushing it. But I'm not so
educating the
and
male
keep
cardiologists.
educating. Yeah, I mean, and I get it because I talk all the time. I mean, if any of you in my last talk on pregnancy and heart disease, and I am the UK. We have a new society called the UK Maternal Cardiac Society, which is for obstetricians, cardiologists, midwives, anaesthetists, and anybody involved in heart disease and pregnancy. And I'm now the president. And so despite having me in my hospital going, hello, heart disease and pregnancy, I am still having to organise at least 1 to 2 terminations a year of people who have been seen in my hospital by my male colleagues and who they never thought to say, by the way, if you were to get pregnant, this wouldn't be good. And I still talk about the lady that came up, had a cardiac arrest, got echoed, ejection fraction, she had moderate heart failure, had an ICD put in, was sent home, 7, 8 weeks later, pitches up pregnant. And then says nobody told her not to get pregnant. So I went, and she was seen by electrophysiologists, heart failure specialists, intensive care, lots and lots of high-level, sophisticated medical input, predominantly from males, because that's who is providing, the care currently in the UK. And I said to them, did none of you think to give her advice or even to ask me to give her advice? Because that's what we keep saying. If you don't know, that's fine, but speak to someone who does. And they went, Dawn, she's just had a cardiac arrest. And I'm like, well, she clearly feels better, But I'm sorry to say it, sex is a normal part of life. Do you know what I mean? So why, we need to be having those open discussions, and increasingly they'll be talking about a really complex case in the interventional. I'll just turn around and say, anyone talked about contraception? And they'll just all raise their eyes. And I'll go, okay, that's fine. You sort the termination out then. Do you know what I mean? Because I bet she's having sex. They think I'm obsessed. And I'm not. But you only need to organise one termination for one couple because they genuinely made a mistake, and you will become as obsessed as I am because it is just grim. And so you're absolutely right. So now we are currently doing something called credentialing. So once you train as a cardiologist, when you do your first 3 years as general, and then you decide to specialise in heart failure, devices, electrophysiology, congenital or intervention. And we are now putting heart disease and pregnancy on every one of those. So it used to be something that you ticked a box somewhere at the beginning, and you turn, 2 men would turn up in my clinic, roll their eyes, and then want a sign off. They can't now. They have to do a lot more. But it's now going to be in everybody. So if you're going to be in heart failure, you've got to have you've got to be trained in the management of pregnancy, including contraception. So we've got that side of it. So by starting to get that mentality, but to be honest, at the moment, if they said, well, what do we do about the menopause? I don't know that we've got enough people interested and knowledgeable about it to be able to keep that, push going. But yeah, I think that's something we all need to be doing. It's a good point.
It's not so much a question, actually. It was a response to the previous point about the connection between cardiovascular disease and stress. So it's coming a bit late, so sorry about that. But it's just really to say that there is an established research literature that recognises the link between chronic stress and physical health problems. So if you've experienced a lot of stress across your lifetime obviously there are different sources of stress, there is a relationship between stress and worse physical health, which is, I guess, is what we would expect, including cardiovascular disease.
So yeah, so I was just saying that what I'm not aware of is data of the male-female differences. Have you got that data as well?
No, I guess it's all work in progress.
Yeah.
But no, because I think there are lots of interrelationships between, for example, poverty and stress and the impact on physical health, racism and stress and the impact on physical health. So there are complex relationships between these things, and I don't think probably in another 400 years we might have a better understanding, but it's all work in progress, isn't it? Even I think the health infrastructure in terms of access to education and what facilities
Yeah.
are there in the local area and what kind of social support do people have. But all of those can negatively impact on health, but also make existing health conditions worse.
And one thing that we never ever talked about was health inequalities. So now health inequalities is becoming on everybody's agenda. So now if you want to invent a new process, bring in some new procedures, you've got to think about what is the health inequalities impact of that. So we're looking at the moment, for example, on increased digital health. You know, that is fantastic, but actually that widens the health inequality gap, because actually people who are from deprivation, they may not actually have a phone that they can use. The phone may not be good enough to be able to take an app. They may not have the health literacy or the ability, you know, digital literacy to be able to use that app. So whilst this is great, it is potentially increasing those gaps. So it's what are we doing to address that as we advance things? So the health inequalities agenda is something that people never really talked about. But now, you know, certainly in my hospital, we've now actually got a consultant in public health who works half with us and half with our local authority. So whenever we decide to do anything or change anything, and she's on our senior medical board with us, because I'm Associate Medical Director at UHCW, to look at what is the health inequalities. And so it's again something that was never ever really discussed, and now has been discussed. But what I keep saying is it can't just be discussed. It can't be something bolted on. It is not a tick box exercise. It is something that has to be intrinsic within the way we think and what we do. That's in a way the same sort of thing that we're discussing. It's about changing all our mindsets. So no, you're absolutely right.
I know you said that obviously women's health is just a personal interest, but what advice would you give to women who find that they have exemplified cardiac symptoms during or around their time of their menstruation, and when they sort of go to their GP, their male GP regarding this, it is kind of just discounted or discredited and said, yeah, there's no link there between menstruation and cardiac symptoms?
That's a really good question. Again, I think we do recognise that actually people's symptoms do change dependent upon their, you know, the cycle. So some people it's at the time before or after. So certainly when I look at, because I tend to get all the young women, because of course I do congenital and pregnancy. So anyone that's, you know, between the ages of 16 and 40 will end up in my clinic, even if it's an area of expertise that I'm not, just because, Dawn, you can deal with them because you know what to do. So yeah, I think we do see that. I think, how do we get your male GP to understand that? No. And I think I think part of it is because it goes back to what I'm trying to teach students, and that is everybody's health journey is different. So how you might experience a heart attack might be different from that person. How you have, you know, you can have two people with exactly the same ejection fraction will be very different symptomatically. You think about AF, one person's asymptomatic, the other person can't get out of bed. So it's about learning to deal with the individual. But I think we're very good at putting people into boxes. You've got that condition, therefore you will behave that way. And it may be the majority of people do, but how do we start to individualise healthcare? And I think the problem is the NHS is under a lot of pressure. I think people are very confident doing the majority. But then when you've got an individual that's not quite fitting in, it may simply be that someone doesn't quite know what to do. And so, yeah, it does. But that's going to happen every month, and they won't know what to do to actually change that. Now, what you want is them to say, okay, I recognise that. I hear you as a patient telling me this is how you feel. Let me think about what the options are. And even if they came back and said, I've no idea how I can stop that happening, I guess it's the recognition that you're being listened to and that you've got a voice. And I think that's not uncommon. And I think it's a combination of just keep going back, trying different GPs, use all the public health forums. I'm not a massive fan of people. I think you've got to be careful. Some of the sort of health forums I think are really, really supportive and really helpful. Other ones can be quite dangerous and toxic depending on how people can get wound up by each other. Do you know what I mean? The sort of Twitter thing. So you've kind of got to get, maybe, have a look for some information with a bit of a pinch of salt. But I think it's about going back and saying, look, this is definitely what's happening. And ask if there's maybe you could be referred. But, I think even if you went to a cardiology clinic, I mean, as long as the rest of you's okay, I know that they would just say, well, sorry. But, the question is could you have something that's, stops your periods or, sort of some of the contraceptive pills, which can be used very, easily in heart disease. As long as you've not got an estrogen-based one, if you've got significant heart disease, then things like the Mirena and the Implanon are really good at just levelling out the hormone levels and therefore potentially, but certainly trying it. There's no harm in trying it. Cerazette is an oral progesterone-only contraceptive pill, which has got no risk in coronary heart disease or in any, I keep saying coronary heart disease, in cardiological heart disease. Well, there isn't no in heart disease, don't record that, but you know what I mean, that might be, effective. So I would try things, but I would just say there's no evidence to what I'm trying, but knowing what we can do, we just have to try for you as an individual. But it's just about finding people with an interest. Sorry. The lady at the back there has been very patient.
I had an iron infusion for the first time this year, and it wasn't a treatment I'd heard about before for heart failure, and I wondered if that was more of an issue for women given menstruation.
Good point. So yes, so absolutely. So for women that are having heavy periods, then obviously you're much more likely to be iron deficient. So the iron that you need for heart failure is often what we call the anemia of chronic disease. So it affects everybody. But if your iron levels are already pretty low because of chronic bleeding, which for some of our, either young women have got heavy periods, or again, like as the perimenopausal state when it can really build up, then it might be greater. And so, again, do we look at women and think about it earlier because you might have worsening levels? No. Would a heart failure consultant ask you about your periods? Definitely no. Am I going to be able to change my male colleagues' thought processes? No. But I think it's a really good point. It's a really good point. To be fair, it's a good point that I hadn't thought about. Now, I'm not a heart failure expert. I mean, I look after heart failure because we all do. And obviously, I look after specific types of heart failure, particularly the congenital post-infarct and the pregnancy. But is it something that I've thought about? No. I do a lot of iron testing on my ladies. I do ask them about their, periods and things. And obviously, I do a lot of pregnancy counselling. But that per se isn't something I've thought about. But again, it'd be interesting. It'd be interesting to know when you look at the trials of things like Ferinject and all the sort of iron infusion heart failure studies, how many women were in there and whether their baseline iron levels were less than men. I don't know is the honest answer. But that's where the whole, in both the talks that I've given, people have asked me questions and it's got me thinking. And I will go back and think, ooh, and I'll probably be asked that question next week of my heart failure and they'll rail their eyes at me again, which is fine. That's what they do and that's good. I think it's just about keep having these conversations. I mean, I was asked to do a slide on the basis of my other talk. And then they said, oh, could you just do a little bit more? And next thing I know, like suddenly next thing and I'm like, I've been given an hour. And so I had to pull this talk together, because normally I've got billions of talks because I talk a lot. My kids will tell me I talk far too much. And it's not really a talk that I've ever had to give. And it is, difficult thinking, what is the right things to be talking about? But actually it's starting to make me think about it more and more. And I think that's it. It will just be a conversation that eventually becomes a tipping point. But yeah, it's a really good point. Really good point.
Okay, just to say we're not far off past. We do have a 15-minute tea break, so just depends on how quick, I guess.
I'll be quick. I'll make a video.
Just a quick one, because this is very enlightening in terms of the focus on women with heart conditions. I hadn't, and I don't know where I am, whether I'm peri or not, but it's interesting that a lot of the symptoms that might be attributed to perimenopausal or menopause, some of our medications also reflect those. And I don't know where to go to the doctor and say, I'm sure it's this or it's that, or is it, doctor? Tell me what to do.
And I think what I understand from talking to people who look after the menopause is I used to send patients for menopausal bloods, because I think I was doing something. But now I'm told that actually your menopausal bloods may not reflect where you are in the menopause. Okay, and that actually if you there is a consultant that works out of Stratford that's doing quite a lot of promotional bit. She's quite private, so I want to be careful. I'm not suggesting we all go to her, because I've never met the woman. So, other menopausal experts are available. You know what I mean? And when you read her blog, which I'm starting to do because I'm being asked all the time about the menopause, and I'm not a menopause expert, so I'm having to constantly try and update myself to be able to support, my rehab nurses, my heart failure nurses, my patients. They decide your HRT not based on your blood results, but based on your symptoms. And so that, to me, then becomes a little bit difficult, because you're absolutely right. I kind of need an objective. I need that means that and that means that. So I think it's all a bit grey, hazy, and we've a long way to go. But at least we're starting to think about it, whereas 5 years we weren't. But no, it's a really good point, and I'm about as useless as a chocolate teapot in telling you how to manage it.
Sorry to bring things to a close. I'm sure we could carry on for a lot longer. Thank you, Dawn, for an absolutely fascinating, thought-provoking presentation.